The following slides will now talk about the different serological tests in relation to the different conditions, diseases, or disorders that they diagnose. These are for serological specimens. The most commonly used specimen in serological testing is serum. For specimen handling, if there is a delay in testing of less than 72 hours, then the specimen should be stored at refrigerated temperature at 2 to 8 degrees Celsius. If more than 72 hours of delay will be seen, then it should be stored at freezing temperature at -20 degrees Celsius. Remember that all specimens that have been refrigerated or frozen should be returned to room temperature before testing. The first condition is syphilis. Other names of syphilis are great pox, evil pox, French, Italian, or Spanish disease. This is caused by an organism called the Treponema pallidum, subspecies pallidum. Mode of transmission is through sexual, parenteral, or congenital. They belong under the torch group. Torch meaning Toxoplasma gondii, others, rubella, CMV, herpes, and non-treponemal test. Syphilis is under the O or the others, together with hepatitis B, HIV, varicella zoster, and parvovirus. Syphilis may be detected using direct techniques to detect the organism itself or through serological testing. The laboratory may either be done as a direct detection of the spirochetes themselves, the organism, or through serological testing. In the direct detection of spirochetes, there are two methods to perform, either dark-field microscopy or direct immunofluorescence. In dark-field microscopy, the laboratory technician should look for the corkscrew movement that is done by the spirochete or the organism. And in the direct immunofluorescence, this is a fluorescent antibody test to detect the organism spirochetes. Serological testing may be divided into non-treponemal or treponemal test. Non-treponemal tests are used for screening and monitoring. They are highly sensitive and very easy to perform. Instead of detecting the organisms themselves, non-treponemal tests detect the antibodies, the reagent antibodies. These are non-specific antibodies against the treponemal lipids. And all treponemal tests, non-treponemal tests, are based on flocculation. Treponemal tests, on the other hand, will detect the treponemal antibodies themselves. There are different methods in non-treponemal testing. Examples are VDRL, RPR, TRUST, and USR. In VDRL, this is both a qualitative and a quantitative test. Specimens may either be serum or CSF. The principle for VDRL is flocculation, but it needs microscopic examination. The antigens consists of cardiolipin, lecithin, and cholesterol. Again, for VDRL, you need microscopes to determine or to see the reaction that happened on the slide. RPR, on the other hand, is the same as VDRL, but with improvements to the reagent. They have added charcoal, EDTA, thimerosal, and choline chloride. The charcoal added in the reagent makes it now visible for macroscopic evaluation or macroscopic visualization. The specimen for RPR is only serum. This is also a flocculation test, and it can be macroscopic. False positives may come from conditions of patients like IM, hepatitis, malaria, and other treponemal infection. Again, the difference of VDRL from RPR is that it is visible. It can be macroscopically visualized. There are three general tests that may be used for treponemal testing. We have TPI, FTA-ABS, and hemagglutination tests. The TPI, or the Treponema pallidum immobilization test, is the most reliable. This is the standard treponemal test. It uses live treponema as a reagent, and it needs a dark field microscope. The disadvantage of this test, though, is that it uses live treponema organisms. The next test is the FTA-ABS, or the fluorescent treponemal antibody absorption test. It uses the indirect immunofluorescence principle, which is highly sensitive and specific, but the disadvantage is it is time-consuming. But due to its high sensitivity and specificity, this is the reference method for syphilis detection. This test uses fluorescence microscope that gives green fluorescence. The last step is the heme agglutination test. These involves red blood cells that are sensitized with Nichols strain. Nichols strain is considered as a virulent strain. A positive result is the agglutination of sensitized gel particles. There are different tests that involves the heme agglutination test principle. We have the HATS, TPHA, and MHATP. The laboratory detection or laboratory technique to be used for syphilis will depend on the stage of the syphilis. We have 4 stages: primary, secondary, latent, and tertiary stage. The primary stage is described to have hard chancre on the patient. For the lab diagnosis, only the direct detection techniques may be used. All serological tests will be negative. For the secondary stage, the patient will experience condylomata lata lesions. Here, both direct techniques and serological tests may be used. For the latent stage, there is the absence of all clinical symptoms. The patient will appear well and fine. But during this stage, only serological tests may be used as the other tests will be negative. And lastly, the tertiary stage, where gummas or gummatous lesions are seen on the patient, only serological tests will be positive, all direct testing will be negative. For easy memorization, serological tests may be used starting from the secondary stage. It may also be used on the latent and tertiary stage. The only stage where serological testing will be negative is on the primary stage. And direct detection techniques will only be useful during the primary and the secondary stage. The next condition is viral hepatitis, and there are 5: hepatitis A, hepatitis B, hepatitis C, D, and E. Hepatitis A is also known as the infectious hepatitis or short incubation hepatitis. Modes of transmission is through fecal or oral route. Diagnostic markers used in serology are HAV antigen and the anti-HAV antibody. The antigen is shed and detected in the feces. The antibodies may either be an IgM or an IgG. IgMs are indications of acute hepatitis, and IgG are indications of natural infection or immunization. Hepatitis B virus is the only DNA virus among all the hepatitis, also called as serum hepatitis and long incubation hepatitis. Modes of transmission is parenteral, sexual, and perianal. The Dane particle is the complete hepatitis B virus that can cause the infection. Serological markers may either be an antigen or an antibody. There are 3 hepatitis B virus antigens. We have HBS as surface, HBE for envelope, and HBC for core. And an equivalent antibody is seen for each antigen. The presence of serologic markers may be used to identify the status of the patient. For example, a positive hepatitis B surface antigen may mean that the patient has an acute hepatitis, and a positive anti-hepatitis B surface antigen would mean that the patient has resolved or has been cured from the infection. A negative test on both hepatitis B surface antigen and anti-hepatitis B surface antigen, but a positive on the anti-HBC might mean that the patient is in the window period. And a negative test on all of them would mean that the patient has not been exposed to any antigens, either naturally or artificially. The next type of hepatitis is hepatitis C or HCV. This is known as the non-A and non-B hepatitis. Mode of transmission is through parenteral routes. Diagnostic test may be through the detection of the antigen or the antibody. For the antigen, it's HCV RNA, which is a viral load testing, and for the antibodies, it's anti-HCV. 2 methods may be used, either indirect ELISA or recombinant immunoblot assay. Hepatitis D virus, also known as the delta hepatitis, requires the presence of hepatitis B for its replication. Parenteral is its mode of transmission. This is commonly severe because of the co-infection with hepatitis B. Diagnostic markers would be the antibodies for IgM and IgG. Again, when IgM is present, this means acute infection, and when IgG is present, it's convalescence. The last hepatitis is hepatitis E. Mode of transmission is through the fecal-oral route, like the hepatitis A. This is a self-limiting hepatitis. Diagnostic markers may either be the antigen or the antibody. For the antigen is the HEV RNA, which is detected in the feces using PCR methods, and for the antibodies, it is the anti-HEV IgM, either through ELISA or through Western blot methods. The next group would be the group A streptococcus, or the Streptococcus pyogenes. Streptococcus pyogenes are gram-positive cocci arranged in chains that can cause several conditions, and the major sites are the upper respiratory tract and the skin, and among all of those conditions, pharyngitis and impetigo are the most common. Laboratory tests for diagnosis of this organism may be anti-streptolysin O or ASO, where the antibodies to streptolysin O enzymes are detected. Serial dilutions may be used for the process, and a normal value of less than 160 Todd units is the reference. Two methods may be used as ASO testing. We have the conventional and the common methods. For conventional methods are the hemolytic tests, like the neutralization reaction, where if there is hemolysis, this would mean that the test is positive or that ASO is present. Common methods may be latex agglutination or neutralization. Another test for Streptococcus pyogenes detection is the anti-DNase B testing. This appears earlier than ASO, so it can be used as an early detection. Measurement for this test is neutralization, where if an anti-DNase B antibody is present on the patient, then they will neutralize the reagent that contains the DNase B antigen, therefore preventing it from depolymerizing. Another test is the streptozyme testing, which is a slide agglutination screening test. Antigens used may be streptolysin, streptokinase, hyaluronidase, DNase, and NADase. This type of testing is used for the detection of antibodies to several streptococcal antigens. The next condition is the Lyme disease. This disease is a vector-borne illness, the vector being the tick, and this tick carries the causative agent, which is Borrelia burgdorferi. Erythema migrans is the clinical hallmark for an early infection. This is when the patient develops rashes. But when the patient starts to have arthritis and neuroborreliosis, then that means that the patient is already at the late Lyme disease stage. Laboratory diagnosis may either be culture or serological testing. For culture, we can use a special medium, which is the Barber-Stoner-Kelly medium, while for serological testing, we can either use ELISA or Western blot. When performing serological testing for Lyme disease detection, we should do it in two steps. The first step is the ELISA or the immunofluorescence, where we will detect the antibodies in the patient's serum. The second step will then be the usage of Western blot, and this will be the confirmatory test or the confirmation for the presence of the disease. The next condition is the typhus fever. The typhus fever is a rickettsial infection, and laboratory testing may be either serodiagnosis or Weil-Felix test. Serodiagnosis, we have three: IFA, IPA, and ELISA. IFA, or the indirect fluorescence assay, is currently the method of choice for detecting rickettsial infections, so this is the gold standard. Rickettsial antibodies are paired with the serum sample. In the Weil-Felix method, this is a screening or a presumptive test. This is based on the cross-reaction of the patient's antibody with polysaccharide antigens. Antibodies from the rickettsial infection would cross-react with the polysaccharide of antigens of some Proteus species. The Proteus species used are Proteus vulgaris and Proteus mirabilis. With the Proteus vulgaris, we use OX2 and OX19, while for Proteus mirabilis, it's OXK. This is done because the rickettsial antigens are considered to be biohazard and are very difficult to cultivate. The typhus fever is a rickettsial infection that is caused by different rickettsial species. Examples of these would be Rickettsia rickettsii, which causes Rocky Mountain spotted fever, and the vectors that help transmit these are the dog or wood tick. Rickettsia prowazekii is causing epidemic typhus, and the vectors are the body or head louse. Rickettsia typhi causes endemic typhus, with the rat flea as its vector. Rickettsia chuchugamushi causes scrub typhus, and its vector is the mite. Coxiella burnetii causes Q fever, and the mode of transmission is through the ingestion of infected milk or the inhalation of barnyard dust. Now, among all of these tests to easily memorize, Rickettsia rickettsii, prowazekii, and typhi would all have a positive OX2 and OX19 test, while the OXK will all be negative. For Rickettsia chuchugamushi, the only positive is the OXK, while Coxiella burnetii will all be negative. Then what test may be used to identify the presence of Q fever? We can use a complement fixation test. Our next condition is the typhoid fever. Now be very careful because typhoid fever and typhus fever might be mistaken for each other. So typhoid fever is an infection. It's an acute infection that is characterized with fever. Fever with more than 37.5 degrees Celsius. Now these are caused by different Salmonella species, which may be transmitted through the ingestion of contaminated food. For laboratory methods, it may be a culture method, which is currently the standard technique for the diagnosis of typhoid fever. Serological tests may also be used. We have the Whittle test and the Typhidot. The Whittle test is a bacterial agglutination test, while the Typhidot is a qualitative test to determine the presence of either IgG or IgM. Examples of species that can cause typhoid fever are Salmonella typhi, that causes enteric fever or typhoid fever, and Salmonella paratyphi, that causes gastroenteritis. The Whittle test is a serological test to identify typhoid fever. Now this test is non-specific as it detects antibodies not only for typhoid but also for tularemia and brucellosis. It has cross-reacting antibodies. The specimen to be used is blood. It measures two antibodies, anti-O and anti-H. Anti-O for somatic and anti-H for flagella. Anti-O detects IgM and anti-H is IgG. The presence of IgM antibodies would mean a recent infection, and IgG is past infection. A positive reaction would be agglutination, and it can be graded from 0 to 4+. The last condition to be discussed is AIDS, or acquired immunodeficiency syndrome. This is caused by the human immunodeficiency virus or the HIV virus. Most of transmission may be from sexual contact, perinatal, parenteral, and transplants. Perinatal is from mother to infant. Parenteral is from needle sharing, usually from drug users, and it may also be blood-to-blood product transfusion. Transplants may be from transplantation of tissues and organs. There are two types of HIV, HIV type 1 and HIV type 2. HIV 1 was formerly known as HTLV3, LAV, and ARV. HTLV stands for Human T lymphocyte lymphotropic virus type. LAV stands for lymphadenopathy associated virus, and ARV stands for AIDS associated retrovirus. The second type, which is HIV-2, is less pathogenic and it has a lower rate of transmission. So what is the effect of HIV on the immune system? Now, the virus, the HIV, is primarily targeting the CD4 cells or the helper T cells. Now, since the helper T cells play roles in the different or with the different immune cells, its decrease or malfunction will also cause a malfunction on the other cells. A decrease in the T cell value is the hallmark of an HIV infection. With CD4 cells malfunctioning, there would be a decreased cytotoxic T cell activity since CD4 cells activate the cytotoxic T cells. There would also be a decreased macrophage or monocyte chemotaxis, and there could also be a decreased NK cell activity. All of these may cascade to a very low immune system since most of the immune cells are affected. That is why an HIV infection may cause AIDS, which is an acquired immunodeficiency syndrome. Acquired because it was caused by a virus that is foreign. Immunodeficient because your immune system as a whole has become deficient. And syndrome because there's a lot of other conditions that may arise from this infection. Laboratory diagnosis for HIV are grouped into three: the screening tests, confirmatory tests, and the staging and monitoring tests. For the screening test, we can use any of these: ELISA, slide agglutination test, or the P24 antigen test. For the confirmatory test, there are still quite a lot. The Western blot is the commonly used confirmatory test, where HIV infection is indicated by the reactivity of two of the following bands: P24, GP41, or GP120-160. If only one of the bands is reactive, then it would be inconclusive. IFA and RIPA may also be used. Viral culture is when the virus itself is grown on a culture. PCR is extremely sensitive. It is when the viral DNA is amplified and identified using the probes. This test, the PCR test, will even detect infections during the window period. And lastly, the staging and monitoring tests would be the CD4 T cell count or the HIV-1 viral load assay. So that ends our discussion for today. Thank you very much everyone for listening. I really do hope I didn't bore you that much today. I wish that was a good refresher for you. That was most of the basic information that I think you should know, but I wasn't able to put all the information that I wanted because I think it would be too much for you for just 3 hours. But if you have any questions or clarifications and suggestions, please use the discussion in the Canvas or email me or use the Canvas mail or even Messenger. I don't really mind. Regarding the discussion in the Canvas, you can put your questions there. But if you don't have any questions, you are still required to answer it. I have put a question there. So if you don't have a question, then you have to answer the question that I put there. Don't worry, it's not anything big. I just wanted to know which topics you would like more help in, especially if they were the topics that I wasn't able to include, like Western blot, the processes, Western blot, the ELISA, electrophoresis, okay, etc. Again, thank you everyone and good luck on your other subjects and the upcoming final exam. Work very hard on your studies so you can pass and graduate. And of course, so you can take the board exam, so you can have those last 3 letters after your name, the RNT, so you can be part of the frontliners. Again, good luck everyone. I hope you learned something from me today. Thank you for listening. Goodbye.